Therapist Thrival Guide, where we cover all of the things that graduate school didn't teach you. Welcome to the Therapist Thrival Guide. I am your host, Miranda Barker. I'm a licensed clinical social worker, and with me is my co-host, Dr. Lucas Vellini.
I'm a corporate executive.
Also a professional recreational golfer.
Yeah, but it's winter now in Minnesota, so it's my off season.
You'll just need to get a golf simulator for your office.
I've been working on it.
I think that'll be perfect.
Yeah. You'll
get that one guy from recruiting, and he'll be in your office
Zach.
all the time. Yeah.
He only putts.
Today we are talking about efficiency in clinical documentation, not golf. However, golf just, comes up.
It'll come up.
Comes up every week. So today we have two amazing guests. We have Erin Opoku and Alicia Exsted. Would you both like to introduce yourselves?
Sure. Wonderful. Erin Opoku. I am a LMFT. I've been practicing for about 11 years, but been in the field for like 15. So.
And I'm Alicia Exsted, and I have been practicing for 11 years as an LPCC.
I don't think I knew you were an LPCC.
Yep.
Man, we have everyone here. I guess we don't have psychologists in the room.
Nope. No psychologists.
Nope, but we've got the other three.
We have a doctor.
We sure do.
Asterisks.
So today we are talking about efficiency in clinical documentation. In the first episode, I remember we talked about things that surprised us about being a therapist. And one of the things that I said was the amount of paperwork, right? I knew there'd be paperwork, but I didn't know that there'd be that much paperwork. And so I think everyone in the room, myself included, has had to come up with little tips and tricks and things that you're going to do to try to be more efficient with your clinical documentation so that we don't recreate Miranda's first few weeks as a therapist, where she was writing diagnostic assessments all night, every night at her kitchen table.
That's everyone's first week as a therapist.
Oh,
yes.
That was rough. That was rough. Erin Opoku helped me through those weeks.
There's probably some tears shed.
There were absolutely tears shed.
Yes.
I was like, I don't know if I can do this.
You thought you were done doing homework.
I know, right. But you know what? It made me a better therapist because I got more efficient with my documentation. However, I still feel like there's a lot that I can learn from the people in this room. So I'm excited to jump into this conversation. Who wants to start?
Well, maybe, I do think it's important to have a firm understanding of why this is even a thing in the first place.
I love it, yeah.
Understand the role that it plays in the healthcare profession and, why there are such rigid kind of requirements surrounding it. And so from that regard, it legitimizes us as a healthcare profession, and it holds us accountable. It gives, the profession credibility, but ultimately when we do it well, our paperwork should serve as somewhat of a metric to evaluate the efficacy of what we're doing with our clients.
Absolutely. And I think that's something that I often forget because even before we started recording this episode, we were just kind of chatting and I was like, who has actually gotten audited in this room? Who actually reads my notes? Because some of them are very good. But, who actually reads these? Is this worthless? But you bring up a good point because it is a good metric for ourselves and for our clients so that we can measure progress and see, how people are doing. But
Well, I've built a really great respect for doing the paperwork, even though it's probably everybody's least favorite aspect of being a therapist, because I have gone to court. And those are the times when you actually have those notes read by several people potentially. And that could make or break a case for a client.
So why were they reading your notes in court? Without really diving into the details of it, why would that happen?
That one was a case of sexual abuse. And so the certain portions of the notes were read in court to substantiate the PTSD diagnosis.
I guess that makes sense.
Mm-hmm.
Yeah, and the court's one big reason, but there are a number of instances in which clients will need their documentation.
Absolutely.
And so, that's part of what we sign up for, is to make sure that they have a chart that clearly documents, what they've been doing, what they're struggling with, the etiology, that led up to whatever it was that they're struggling with, their progress, their strengths, their resources. And, and so and again, to take it to the extreme, like we've done in a few other episodes, it's like, imagine what this profession would look like without any requirements for paperwork. That'd be a nightmare. It would fall apart immediately.
Well, I think the other piece that I'm thinking about is actually I've utilized, looking back at any of the documentation I have done with clients and utilizing that in session with my clients to go, look at where you've come from.
Mm-hmm.
Like, look at where we started and what you've done to grow into the person that you are today. So it's validating for clients as well to see kind of that progress.
Yeah, the chart should tell a story, more or less. And it should be chronological. And yeah, you should see some momentum and some shifts. And, so like the different, especially relative to like those initial first few weeks of therapy, when you get those initial assessments in, you kind of establish a baseline, you paint a picture of where the client is at right now, today, in this moment. And then, that's something super helpful to look back on, and so there's definitely value to it. But let's be clear, it's horrible. So we're not going to try to convince anyone otherwise.
No.
And I'd just say right now, like, don't put the pressure of a goal on yourself to one day love doing clinical documentation. No. That is not the goal.
Do you you love clinical documentation?
I don't love clinical documentation. I get a great satisfaction when it's completed.
Okay.
So I can sit with the distress or the discomfort of doing the documentation. And then when I get that green circle at the end of the day, that gold star for myself. That's what I like.
I love that.
I mean, isn't that the same with anything we hate, chores or anything like that? Gold star is what I'm looking for.
Do you get any, so like a self-administered gold star?
Yes, exactly.
That works for you?
Yep.
I need it externally. I need to be celebrated for every time I finish a case.
You could totally do that for yourself,
I
right?
can't, no.
Oh.
No, I'm a youngest child.
Oh, that makes a lot of sense.
Yeah. Yeah. I see all the pieces falling together in your so maybe let's break down like the different aspects of clinical documentation and then like clarify the role they serve, and then let's get into other things we found that work for ourselves relative to efficiency or what we know other folks do. I'm sure between the four of us, we could think of 25 different styles amongst our colleagues of how people tend to roll with this. But when it comes to clinical documentation, there's of course the initial kind of get-go of intake, informed consent and kind of all of those pieces. A lot of that has been streamlined through the electronic health record. They can complete a lot of it before they even come in. You can review it before they even come in. Back in my day, prior to the EHR,
I think
which
three
let
out
us
of the
tell
four
you
of
about.
us,
Yeah.
Lucas,
Yeah.
have done the paper.
Never have I done a paper informed consent. So please.
They're lengthy. Like, they would take a while.
Yeah.
It would take up a good chunk of that first session just explaining, all HIPAA confidentiality. And it's like we still explain that and review it and break it down. But like going through it paper by paper and having them sign it right there in front of us was minimum 20 minutes of that first session,
Sure.
which I couldn't stand because those are like the most critical moments to join, and kind of establish rapport and start getting things going. And so the EHR is really streamlined, like the administrative aspects of the health record, but then we're getting into the more clinical aspects, the diagnostic assessment. That's the big one. Those are the beasts.
Did you also have to do that on a typewriter?
I didn't have to. I would by preference.
Of course.
Only when my
Handwritten.
feather ran out of ink. But that is crazy, too, to think about. Like, I've had professors who, it's like their health record at one point in their career was a stack of Post-it notes scattered all over their desk.
Sounds like a professor.
Yeah. Yeah. And that's just what it was for a long time. Again, a lot of aspects of our profession that we know well today are relatively new, and it took a while for us to become a formalized, well-regulated profession. But so it's DA, treatment plan, the standardized assessments that you implement, whether they're, like PHQs, SDQs, stuff like that, or kind of your own qualitative methods of assessment and evaluation. Yeah, and then the case note. So should we start with the DA? And they should all sync together. Like when I say DA, treatment plan, case note, like see those as like kind of like a interactive whole.
Different layers of the story.
Yeah, the DA kind of tells the whole story. The treatment plan says what you're going to do about it, and then the case note is the documentation of how things go week by week as you're trying to work toward completing the treatment plan or the goals on it. But yeah, DAs can get, man, I could do an intake with one client and write a 40-page DA or a 4-page DA.
Yeah.
I think, oh, go ahead, Alicia.
Well, and I think I really stress for myself and for any clinicians that I'm working with, do as much as you can in a session. Don't be doing all this stuff, like you said, an hour after you go home at night at your kitchen table. And I think for the DAs, that can be really hard depending on the age or the complexity of the case.
Yeah, I think with like case notes and treatment plans, you can get into a good groove where, you could just find what degree of discipline works for you to make sure that you go home each night with your stuff tidied up. But a DA doesn't necessarily fit into that.
Yeah,
We need to
that was
get
a lot
more
harder.
creative with DAs. We need to be more flexible. So like how maybe we could talk about our process of, kind of where we started with DAs and how we found ourselves to become a lot more efficient and less overwhelmed by them.
Yeah. I think when I was that brand new golden retriever puppy clinician, right? It was a lot of, I needed to get it right. Unless once I was able to kind of understand a little bit more that this was like the start of the hypothesis of what was really going on with this individual, and really like broke it down to what is this person experiencing in the moment that they presented with, to really kind of base it, the diagnoses, right, to be able to bill for insurance and all of those bits and pieces, starting there, because we only have that hour to really kind of get to know a person's world and all of their history. And so you're probably not going to be right off the bat.
And you don't have to be.
And you don't have to be, right?
Yeah, there's not an expectation for you to be. It's like be right, make sure it makes sense, and it's like empirically sound based upon the information you do have. But it's like diagnostic assessments are not concretized when you sign off on them.
And it's about, like, I think a great example would be if, a clinician was looking at some of the symptoms that someone was presenting with, recognizing that we have a diagnosis that it fits, but also recognizing that within those diagnoses, we can narrow it down even further. Of what is this a long-term depression? Is this a first episode of depression? Is this related to a recent trauma? Or is this chronic, traumatic events throughout this individual's years, right? Like looking at those bullet points to then kind of form that hypothesis, kind of moving forward.
Yeah, and that as you do that, it's all within the scope of your competency, because the DA informs the treatment plan. And so if the DA doesn't organize around an issue that you're equipped to competently work with and treat, then the whole chart's going to be out of whack. So that's always something to keep in mind too with the DAs is it's meant to demonstrate what it is that we will be working on here in our clinical work together. And yeah, I think, well, even with DAs, like EHRs really have come in huge.
Oh, yeah.
Because it puts an extra burden on the client, to kind of do more legwork coming into it. But one, I think that's helpful, for them to sit down and at least it's a matter of how you have your EHR set up. I mean, I was in private practice at one point with a pretty nimble EHR. That was one of those EHRs where it was built exclusively for like small behavioral health private practices. So like nothing more, like it wouldn't work in our system because they weren't robust enough. But by the time the client would complete the initial paperwork, it's like 80% of the DA was done.
Yeah.
You know, they complete all of their background information. We don't need to necessarily be writing that, you know, so that's gone a long ways in even making the DA more efficient. But it's still up to the clinician to like conceptualize the DA, you know, and tie everything together. And I do think that's part of the work that can be the most interesting as far as case notes go, like the integration of all of the findings to create a coherent picture of kind of, where the snapshot of the client. And that's where, you know, you can get lost in it. And like I was saying, it could be 40 pages or it can be, you know, sometimes as short as 2 pages, you know, and so I don't think you can get to writing a super efficient, you know, 2 to 4 page DA without at least taking some time to get pretty good at writing a overly unnecessarily thorough and long DA.
Oh, yeah.
Yeah.
Mm-hmm.
Well, that's what I found over my years of practice is initially it was check the boxes. Like, oh, did we cover legal issues? Did we cover family history? All of those things. And it became less about those and more about writing the narrative. It was like telling a story and like really trying to figure out like where might this have started and how old were you and what impact did that have on your life, instead of just have you had any legal problems? Do you abuse substances? Instead of just checking the boxes.
Does culture play a role in your life?
No,
So
not
many,
at
so many
all.
clients would just be like, nah. It's like, oh, okay. All right, we'll move on. And so, like, I do like the notion of, and I did a training on this at one point, and I did just end up calling it like how to write a shitty DA. But the purpose was efficiency.
Yeah.
You know, but the best way to learn how to write a shitty DA is to learn how to write a really, really, really good DA. You know, and when I say a shitty DA, what I mean is, and I think this is, you know, a kind of a place to get to, and kind of how I would say I function at this point is like the bare minimum, the bare essentials. You know, it's like with all clinical documentation, it's like don't exclude, you know, like a crumb of relevant information, while at the same time, it's like don't include any unnecessary information. You know, that and a lot of this, I would say for me, a big help in applying that to my clinical work was just a lot of my training in academic writing, because a huge part of academic writing is taking a sentence that's 14 words and saying the exact same thing in 7 words. You know, and so like learning how to say more with fewer words, you know, and less language, not only does that read more cleanly, you know, it's when you do coordinate care, which is another aspect of clinical documentation I don't think we mentioned, but coordination of care with other healthcare professionals, probably one of the most critical roles, you know, that well-done clinical documentation plays is so we can coordinate care and keep all of, you know, our clients' providers on the same page. And they'll appreciate an efficient DA that is like every sentence in the DA is meaningful. You know, and it gives them information, and there's no waste, there's no jargon, there's no fluff. But yeah, you can't start there.
Agreed. I think it's that process, right, where someone that's been doing these diagnostic assessments for the last 10 years, when I'm able to then, as coordination of care, if someone is coming into my office and going, oh, I'm going to look at their DA, but where am I going to actually look is the clinical summary. Those are the bullet points, and like the thought that we put into those clinical summaries will help lead us in where we're going with our treatment. And I think that's why I feel like being able to be concise and use very descriptive, understanding words clinically in that clinical summary will help actually ease the building of the treatment plan, and then therefore the case notes too. Purpose notes.
Absolutely.
Yeah, so if you're going to do one aspect of your documentation really well, it's definitely that summary at the DA, that at the end of the DA that ties everything together. And yeah, I mean, you should, even if it's a 12-page DA, you know, it's like they got a lot of treatment history, a lot of complexity. It's like there should still be a 1-page summary at the end that tells you just about everything you need to know from a quick glance. And so, yeah, I mean, a lot of it, you know, these are things to just find people that you work with that have kind of found their groove in clinical efficiency, because none of us got there alone. You know, even like your mentors and getting there are right here, right now.
Absolutely.
And, you know, so ask questions, you know, and definitely invest in that being kind of a key component of where you put your initial focus, you know, once you're getting out there and rolling with this work is, you know, getting a good grip on clinical documentation so you're not overwhelmed by it, you know, so you don't drown in it. And yeah, just know it's going to suck and it's going to be a learning curve, and don't put pressure on yourself to find joy and meaning and purpose in it.
Well, and I think that something that really helped me starting out writing DAs was reading other people's DAs, like finding people who I felt like were really solid clinicians and being like, can I read a couple of your DAs? And because then you get a good sense of how you should be writing some of these things. And I like that you talked about how, you know, your academic research and writing in academia really helped you. Because I feel like my court writing, being in child protection, was absolutely what helped me write DAs, and just, you know, writing objectively, saying client reports this, you know, stuff like that. But it's so helpful to read other DAs and just to kind of get a sense for how long should some of these portions be? Like, how much detail should I go into some of this? And then the more I was writing DAs, the more I was reading DAs, the better I got in structuring my sessions and structuring my diagnostic assessment sessions so that I knew what I needed to be asking. I could think to myself, okay, this person is saying these different things. I really need to make sure to spend some time on this portion of the DA. And, you know, you start to kind of visualize the DA in your head and think, okay, this is how it lays out. These are the details I need to make sure to ask about, and, you know, those sorts of things. And so I think that, yeah, like the first, you know, 20 DAs I wrote were probably pretty rough and probably had way too much information in them too. Like but I think the more I was doing it, the better sense I had for what was actually important to have in those DAs and what I needed to be asking, so that I wasn't just, you know, saying, do you have any history of legal troubles? Or, you know, like you're digging into the story and not so much just, you know,
particulars.
Yeah.
Yeah. It's like when you can cruise through the particulars, even have the client complete those ahead of time. Then you get to really dig into the meaningful stuff and the essence of what brings them in. But yeah, you made 2 points that I think, you know, are worth emphasizing. The first one was how your legal writing, you know, child protection, influence your clinical case documentation. And when I do clinical case documentation, I make myself as invisible as possible.
Oh, yeah. That's,
you know, it's like be super objective with it, you know, and take yourself out of it altogether. And especially if a record ever winds up in court, and if it's just loaded with your interpretations,
opinions,
your opinions, that's going to create problems for you and the client, you know, that they're reviewing those records on behalf of. And, you know, as you're going into, you know, from there, when you were talking about, you know, condensing them more and more, it's like when you write a shitty DA that's just kind of like just over the threshold of the bare minimum, that doesn't only serve the purpose of efficiency for the clinician, but it does serve a purpose in protecting the privacy of the client. You know, because if there's unnecessary information in their record that doesn't need to be in it, and if that record does get subpoenaed, you know, or court ordered, you know, for review, you know, the less of that stuff that's in there, the better it's going to be for them, you know, and then the less you have to answer to as well. And so, you know, this isn't, but when I say that, like, it's not a suggestion of kind of like manipulating, you know, that system. It is just being aware of the system, and working within it in a way where, yeah, you're reducing liability. And why wouldn't we do that?
Well, but I also think there's a line with, like, if this client transfers care, or, you know, there's another person involved that needs to be reading this DA, I want them to have a complete clinical picture. So, you know, while some of this history may not necessarily be relevant, like it still adds to their story of how they got here. And so there is kind of a line.
So then it's relevant.
Sure. Yeah.
And it's, you know, it's like, it's not a clean line, you know, of the bare minimum and, you know, being under that or above that. But yeah, I mean, I think intuitively we all just kind of get a sense of like, does this matter? Is this relevant? And we kind of just start to know.
And I use a lot more quotations. If you're doing it in the moment with a client, especially in intake, I'll just put it in quotes. So it's client reported literally in quotes exactly what they wanted to express about that.
So let me ask you, Alicia, when you, like, if you sit down at a DA session, do you pull your laptop out, you have the DA up, and you're like, let's walk through this? Like, how do...
Yeah, I do. Yeah, because I know there's clinicians who like to write it out on paper and then transfer it to the electronic record. And I was like, well, that seems like double the work. Maybe that's good for their process, but for efficiency, it isn't. And so I do apologize. I say, you know what? In normal sessions, I will not have my computer out, so I apologize. But today, for the intake and for the treatment plan, I'll have it out.
That makes sense.
Yeah, I 100% agree with that. I kind of preface, you know, the first session, initially, even when I make that first initial contact with the client, I say this first session is going to be really businessy, and I'm going to have to go through some paperwork, and it's going to be a lot of questions about what's been going on, right? And so then again, when they come into the office, it's about reiterating that and kind of giving those expectations of, I'm going to have my laptop open for this session. It's not going to be the norm. I don't like it. And it's necessary for me to get some of this stuff done. So they have kind of a clear idea of this isn't really what therapy is. It's not just me typing in a computer.
She's also not just hanging out on Facebook.
Exactly. Yes.
How do you know?
It's always in the
How does anyone know?
background tab,
Oh,
Miranda.
That just eats up memory. And so I like what you're saying, that even though you don't love it, you know, you don't like doing it that way, but you found that that's what works best for you.
Yeah.
And if that's what works best for you, that's going to have an effect on your clients.
For sure.
And so we probably all have very different like DA styles and initial session styles. So maybe, yeah, that could be helpful to share. I've taken full advantage of the EHR and getting all of that nitty-gritty background information that needs to be in the DA. And I'll just make sure that it was sufficiently completed before that first session. And then my first sessions really are, I'll give a verbal informed consent, you know, because that's necessary, even though they already signed off on all of it. I want it said in person. You know, I want to be present with them to make sure that they actually comprehend it. And then I just go right into a genogram. And that's all I do. Like I'll spend as many as 2 or 3 sessions doing a very, very thorough genogram. And when you get genograms are incredible. It's like they almost seem like silly at first, you know. But my gosh, are they powerful. Like when you do a thorough genogram, it's like you have one piece of paper in front of you that's just, you know, shapes and lines that tells you a massive story. Like everything you need to know about that client and that system should be evident just by looking at a snapshot of their genogram. And so then I can just, between like them filling out all the particulars and my genogram, that's far more than what I would need to complete a DA. And what I like about that is it allows me to kind of just get right into it and, you know, have that first session reflect more of what the ongoing sessions will look like. And that's just what gives me like energy, you know. So I feel like that allows me to be most myself during that initial encounter with clients, which is critical. I want them to know who I am, you know, before they decide whether or not they're going to come back. But I do that in a way without sacrificing any data. You know, it's going to be helpful and relevant.
When I think along with that, I've really changed the way I ask the questions for a diagnostic assessment. I do not read them. I'm not like, has there been any history of legal issues? Has there been any history of this or that? Right? Because especially if they're there, they're struggling, they've got depression, they've got anxiety, and they're in the midst of it, and that's why they reached out. They're suffering. They're not going to be like, so any family medical history that's significant? And they're like, no. So instead, I will ask it broader, like any mental health history that you know of or suspect, right? Like families suspect that somebody had depression or anxiety, but it was never diagnosed, right? Or like, is there any significant medical history? And I'll list off a few like cancers or heart attacks, heart disease, like all these things, because initially you might be like, well, no. well, I mean, my grandparent passed away, and oh yeah, they had a stroke, and and that could be a very significant part of their history that you could get with a genogram, and I get with asking it a different way.
Yeah.
Yeah.
Yeah. But I'm sure there was a time when you first started where you did just kind of read the
Oh,
question.
for sure.
Yeah, and like that's
Initially.
okay. And like not only is that
It's a
okay,
good start.
but that's great.
Yeah.
It's like I'm going right back to my very first diagnostic assessment in elementary school when I was not much older than the children. And like, my gosh, having a standardized piece of paper with all the questions that I just got to read was great.
Yeah.
And so it's like, lean on that initially, that's a very appropriate crutch until you find your groove. But when you do that enough times, it's like you start to see the circularity in the questions, and you start to get a different understanding of what these questions are actually getting at, and then you just ask them in your own way.
Yeah. When I first started out, I was so terrified that I ended up bringing home, back then it was paper copies, bringing home a blank paper copy of a diagnostic assessment and asking my partner the questions. Because I was, I'm not going to write it all down, but just to get myself familiarized with the questions, and we kind of made it comical. And
Oh yeah.
But
No,
I think,
that's great practice.
there's so many ways that you can get familiar and feel comfortable with what you're going to be asking.
I don't think that's silly. I think that's a great idea.
I love that idea.
What was the diagnosis?
That's for another podcast.
Nothing
Lucas.
I ever verbalized.
All right, so those are DAs. I think with DAs, yeah, when you're first building a caseload, especially if you start working at a big agency, that just has referrals through the roof. It's like you can fill up that caseload as quick as you want. So it's appropriate to work with your supervisor, and make sure that you're getting your intakes at a reasonable interval, so that you can keep up with it. And so that, advocate for yourself in that regard if your supervisors aren't already on top of it. But yeah, with DAs, it's like, those don't necessarily lend themselves to, tie those up before you punch out for the day.
Yeah.
Sometimes you just need to push them out, maybe dedicate a block at the end of the week,
Yeah.
where you just kind of focus on wrapping up those DAs and polishing them up. But when it comes to the treatment plan and the case note.
Before we jump into that, I just wanted to say one thing that helped me tie up all of those DAs when I had so many, because I started doing kind of the block thing where I was like, okay, I'm not seeing clients on Fridays. I'm just going to write them all on Fridays. And that was a nightmare.
Yeah.
It was so bad because
It's a horrible way to spend
I can't
Friday.
do that. You just you'd write maybe one, And so I actually ended up saying, I'm going to write one. I think I said I would write one every day, and I would just say, like, at the end of my day, I would have an hour and I would write one DA, because one is so much more manageable than being like, I'm going to write 24 on Friday, And so it's like giving myself really small steps, or I would say, like, okay, this is a week where I'm going to write 3 DAs this week. And trying to just have that be the expectation, because that was really helpful for me to actually just break it down into smaller steps in that way.
Well, and I did this for myself after learning, like, I can't take it home with me all the time, but also for new clinicians when we're doing trainings and stuff. I recommend have a DA, have an hour or two break afterwards, and then have another DA.
That's a great idea.
Because then what if you have 2 clients that have very similar presentation? I had that happen once. I did back-to-back DAs, and it was like a 15-year-old female with suicidal ideation and depression whose parents are getting divorced, who has 2 siblings. I started to confuse the 2 of them because that initial presentation was so similar, then trying to remember the details afterwards, that it would have been good to have that hour in between. And it gives you that break to transition to hearing a new story.
That's really good advice.
Yeah, it reminds me of one of my favorite pieces of advice from the Dalai Lama, which you were saying, Barker, reminded me, was when people have a list of things they need to do, it's like we tend to write it all on one piece of paper, like stacked on top of each other, but then all we see is this mountain of things we need to do. And so his suggestion is write your to-do list on like a stack of Post-it notes and have just one task per Post-it note. So you just see one at a time. Once you do it, you rip that one off, you're done, and then you go to the next one.
Small steps.
And then you can give yourself a gold star.
Where do you keep your gold star?
They're all in my mind.
Oh,
Yeah.
oh,
I just visualize
I
them.
love that.
Gold star.
I love it. I love it.
I'm gonna try that. I know it's not gonna work.
It's
though,
not gonna
but
work for
I'm
you.
still gonna try. All right. Yeah. So DAs, it's find your groove. Find your craft with them, and just keep in mind that's something that'll happen over time.
Yeah.
Treatment plans and case notes. I do think as far as thriving goes, when you do find yourself in a groove where you can wrap up at the end of the day and know that you wrote all of your case notes for that day, it's like everything's better. It's like you just go home lighter. It's like you relieve yourself of the late night ruminations around all the things you didn't do yet that day or that you need to do tomorrow. It's like when you're behind on case notes, it is just like this growing dark cloud that looms over you in everything you do. But yeah, and whether that's, it's like, are you all able to like sneak in the case notes in between clients?
I
Yeah.
am. Yeah.
It
Yeah.
depends on the client. Like typically, yes. But there are some case notes where I'm like, that was a lot. Like, and I just wanted to say too, like the average case note, takes typically like 10 minutes for me to write, if even. Like probably
All of you?
like
Yeah.
What?
so so what I was gonna say with that though is that like, I mean, there are so many sessions that really like will end on the 57th minute, and then I have a next client on like at the hour, and so I mean, like there are some case notes I can write in like 3 minutes, but sometimes you're just like, I don't have time to write this. I'm going to have to write this later. And that's when it starts to feel like it's snowballing, when you have like the back-to-back clients and you aren't giving yourself much of a break in between. And so it helps me tell myself most case notes take max 10 minutes to write. And so it's like if I have 3 case notes at the end of the day, I can get this done in 30 minutes. Or like I think that's even actually pretty generous, even as I'm saying that. I could get these done in like 15, 20 minutes. And so then when you break it down in that way, again, that's what helps me get my case notes done at the end of the day. Because I say to myself, oh my gosh, you have 5 case notes you need to write. But then you're like, okay, this is actually not going to take that much time. Like if I just think about how the average one does not take very long, I can whip these out, and then I can have that lighter feeling at the end of the day, because that's my gold star, right? Like that feeling that you're talking about, Lucas, is the gold star for me, where it's like, I don't have to think about this. I don't think I'm someone that ruminates at night on case notes, but I will get to work the next day and be like, oh man, I have all of those names are in red, because it means that I haven't done the case note yet, and like just being able to look at the calendar and seeing all of the case notes done, I'm like, yes. And so it's that inner feeling that is the gold star for me. But again, I mean, I think you have to break tasks down and thinking like, maximum, this is going to take this amount of time. And so like if I set aside 20 minutes, I bet I can get all these done, and having that inner dialogue with yourself.
And this is practice management stuff too, as far as like 90837, for like full hour therapy is 52 minutes, not 60. So like if
53
you
plus, Lucas.
53.
Oh, well, I guess that's changed. I'm sticking with 52. They can never possibly prove that. So if you want to cut those sessions, like if you're disciplined to give yourself a 5-minute cushion, to pound out a case note, which depending on your EHR, like some EHRs are pretty clunky, and they don't lend themselves to like a 2-minute case note. I've worked on EHRs that were super swift and intuitive, and it was very reasonable to write a 90-second case note in between clients. But yeah, sometimes you do it in between clients. Sometimes you save it for a chunk at the end of the day. Sometimes it's, during your lunch hour, you write all the morning, case notes. And then at the end of the day, you only have, another 3 or 4 to write before you head out. But yeah, giving yourself that peace of mind, and finding a way to get yourself there can be, especially once you have when you have a fully established caseload, and you're maybe doing like 1 or 2 DAs a month, you know, because you're just full. Giving yourself that peace of mind of going home every night with your documentation completed is significant. That's a very worthy goal to work toward. But with case notes too, like I think there are ways that you can find amusement, you know, maybe not like meaning, but I tend to amuse myself in my case notes. And this serves 2 purposes. One self-amusement, 2 is to, I write my case notes in a way that when they do get audited, they will disorient the auditor by using like that's when I'll use the most obnoxious academic. Like it's all my case notes are written in the language of interpersonal neurobiology, and I say like bilateral neural integration and like stuff like. So it's like people read it, they're like, all right, I don't know what this guy's saying, but he sounds like he knows what he's doing. So I'm just gonna leave it there.
Is that to cover up because you don't know what you're doing, or?
Yeah, just cover up a lot of things. Mostly low self-esteem.
Oh my gosh. What do you all do to be efficient with your case notes?
I tell my clients in that intake session that future sessions will be 53 minutes.
Yeah.
So that they're not like, what? I didn't get my full hour, right? So I already set that precedence right away. And then I stole this from actually a therapist I saw, is he had it at the 10-minute to finishing mark, but I do it at the 5-minute and have like a little chime on my phone that goes off. So it's just like a bling, 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 right? And that's the reminder to me and the client that we've got 5 minutes. Is there anything else you wanted to kind of talk about? It's a little harder when you're doing telehealth, but with telehealth, sometimes I will just concurrent chart if it's going a little over that 53 minutes. And I will just do it on my iPad while I'm on the computer screen.
And so your 5-minute, your chime at the end of the session is like a 5-minute warning.
5-minute warning for me and the client.
Yeah,
Is
I
that
love
disruptive?
that.
Is that disruptive to the client?
I think if it was a fire alarm, it would be disruptive, but it hasn't been. I think people get used to it really quickly. I got used to it when I was seeing a clinician who did that. And I found it actually really helpful because you might be in the middle of something heavy and you're like, oh, we've only got 10 minutes left. Okay, how do I reframe where we're at? How do I come back so I can leave this session not feeling awful?
And when you just orient a client toward that being the method, I think that could be super effective. What I hate, what is awful, is when like some therapists literally just have like a buzzer, and like when the buzzer goes off, it's like, all right, all right, on your way.
I have never
time's
heard
up.
of
Like
this.
a singing bowl,
yeah.
like you could do a singing bowl.
I have never heard of this.
This is exactly how I do my practice management as well.
This is maybe what I need.
I have a clock that the clients can see, and I have a clock that I can see, and as I'm watching, I'm going, okay, I've got this much left, right, with the client. Where are they at in the story, right? And all my clients, I train them, right, to go, yep. If I'm going, hey, we've got about 5 minutes left, that's your indicator of wrap your story up, right?
Yeah.
And yes, there's that learning curve as a therapist to kind of go, how does that work, right? How are you going to integrate that piece into your practice, right? But I think it has to kind of come from what, if it's a buzzer or if it's just my visual cue. A lot of times, depending on how my office is set up, I will actually get up and walk over to my computer. So my clients know that that's the indicator that, yep, it's time. We've only got a few minutes left. So then I can, one, pull my calendar up, make sure we have another follow-up appointment. For clients that I've got on routine appointments, I still get up and I walk over because that's their cue to go, yep, we're wrapping up the session. I can still listen. I can still engage, right? If you're doing different modalities of like EMDR, things like that, I think it's a little bit different, but I think you actually have to have a more concise practice management. If you're doing those modalities, you have to keep your eye on the clock to allow for the client to re-engage into the set,
to come
actual
back.
reality,
Yeah.
right?
Yeah.
And so I think a lot of that practice management has led to that, being able to get my case notes done in the 7 minutes, 8 minutes, whatever it is, as you're walking the client out and you're running back and going to get more coffee or run to the bathroom for the first time in 9 hours or whatever that might be, right? if you have that practice management built in, you allow yourself that time to do the case note. It's not an always and forever,
Right.
unfortunately, right? There's going to be clients that are not going to be able to, re-regulate, to be able to engage into real life stuff again. Yep, those case notes are going to wait because you also have to take care of yourself and make sure that you go to the bathroom and,
And have
refill
time
your
to
water.
process it.
Yeah.
If it's
Yeah.
a heavy session, you might need time before you do your case notes so you don't miss anything.
Yep.
Well, we are just about out of time, and so I just wanted to wrap it up. I'll walk around. I'll walk across the room and grab my computer. Just kidding. I'm curious. Any last tips you both would want to share for new clinicians that are navigating this and trying to be more efficient with their clinical documentation?
Yes. One thing is do as much as you can with clients. As far as like if you need to write a letter for gender affirming surgery, do it with the client. They can be a part of that process. They'll know what's in it, and you're not going to be spending an hour outside of your sessions doing that. And it can be very therapeutic for both of you, right? To go over the diagnoses and what you're adding and what do they feel comfortable having in that letter. So whether it's an emotional support animal or a gender affirming surgery, I do those in sessions. So that's one piece that keeps me efficient with things that might be beyond the scope of just the regular case note and treatment plan. Do treatment plans in session. That way you can get the quote from a client. What do you want this goal to be? You can make pretty much any goal measurable, right? So you can get creative with that as well, and it doesn't have to be the standard, like learn and practice 4 new coping skills over the next 6 months, right? You can get creative. And I think that helps them feel like, one, they actually know, because how many times would you send an email treatment plan, they probably don't read it, and they just sign it, or they sign it on the practice document without really knowing what they're signing, and so they can be a better part of that process. I also do not take work home with me. I will stay an extra half hour to finish case notes if that's going to feel good for me, or maybe I have an hour the next morning and I'll just block that for that paperwork, because I found when I did work at home, I got really resentful of the work.
Yeah. I think the last thing that I'll kind of wrap up with is making sure that you are challenging yourself within how you're writing, and recognize that these are clinical documents and not a novel. They don't have to be. Making sure that you are using those concise pieces, because that will tell the story. It gets you through all of the auditing. It gets you through all of the, like conceptualization. There's a lot that we keep in our brains, and it doesn't all have to be written out.
Yeah, and if you find yourselves writing case notes and DAs that are more like novels than clinical documentation, figure out how to write a shitty DA and then go write an actual novel with all of that extra time and energy that you'll have now.
There you go. Well, awesome. Thank you both so much for joining us and sharing your knowledge all about efficiency and clinical documentation. And we will see you next week.